It was really a great meeting, and there was a lot of advancements which were presented. I think the key ones were in relapsed refractory DLBCL, but I'll start with frontline DLBCL, and I'll maybe get going with the thought that bispecific antibodies have really made a significant progress in both DLBCL as well as follicular lymphoma. And while they are approved in third line plus, they are making their way to second line and also to front line. So that's the general theme. I'll get started with frontline DLBCL. So in frontline DLBCL, we participated in a study of glofitamab plus R-CHOP or glofitamab plus Polar CHP, where glofitamab is introduced from cycle 2. So first cycle could have been R-CHOP or Polar CHP, and then glofitamab starts in cycle 2 with a ramp up. And at the end of treatment, the overall response rate and complete response rates were really high at 93 and 86% with glofitamab R-CHOP and 100% and 96% with glofitamab Polar CHP. And importantly, most complete remissions were achieved in the first interim assessment. In terms of durability, we have at 24 months, about 80% or so patients were progression-free. So I think that's a very important study moving glofitamab to the frontline therapy. It was also good to know that the CRS rate was very low. Only about 10 or 11% of patients had CRS, and mostly all were grade 1. Only a couple of patients had grade 2, and there were no grade 3, grade 4 CRS. And only 2 patients out of 80 received tocilizumab. So these are things which are commonly going through the minds of physicians and who are treating with bispecific antibodies, like can you do this as an outpatient? Can you do you need to use tocilizumab? And this trial kind of showed us that maybe after debulking with 1 cycle of chemotherapy, when you introduce a bispecific antibody in cycle 2, they have very high efficacy, durable responses, and low toxicity. There was another study which was presented in frontline DLBCL with glofitamab plus Polar CHP, and this was also in frontline DLBCL, where 2 cycles of chemotherapy for first use, and then glofitamab was introduced in cycle 3. And even in this study, they saw a very high CR rate of 90%, and they had a shorter follow-up, but at 12 months, 95% of patients were still in remission. Very high MRD negative rate, and again, CRS rate was very low at only 10%. Now, epcoritamab, the other bispecific antibody, was also tested with Polar CHP. This was actually presented at the EHA meeting, where epcoritamab was started in cycle 1. And again, they saw very high response rates, very high CR rate of like 97%, but the CRS was higher. So it's possible that like if you introduce bispecific antibody from cycle 2 or cycle 3, that might lower the CRS rates. In the EPCO Polar CHP study, the CRS rate was 51%, although most of the CRS was all grade 1, grade 2. There was no grade 3, grade 4 events. And about 20% of the patients needed tocilizumab over there. So again, like, just showing the combination of the, how strong the efficacy is when you combine bispecific antibodies with frontline chemotherapy in DLBCL. The next key takeaways were actually in relapsed refractory DLBCL. And there were 3 large randomized studies which were presented, the POLARGO study, the SUNMO study, and also the study with the STARGLO study. And these were all testing bispecific antibodies in combination versus R-GemOx in relapsed refractory DLBCL, and they all included patients who had in the second line as well. So to start with the POLARGO study, which made it to the plenary session at ICML as well as at EHA, this was looking at polatuzumab with gemcitabine, oxaliplatin, rituximab versus R-GemOx. And this study included a significant number of primary refractory patients. About 50% of them were primary refractory, and it showed a significant improvement in PFS and OS addition of polatuzumab to R-GemOx compared to R-GemOx. And then this, importantly, we thought like polatuzumab was going to only benefit in ABC subtype, but in this study they saw improvements in both GCB as well as ABC subtype. The second study I'd like to talk about is the SUNMO study, which looked at fixed duration combination of mosunetuzumab plus polatuzumab, so combining a bispecific antibody with an ADC and comparing it with R-GemOx. And in this study, again, over 50% patients were primary refractory, so that was close to almost 60% in this study was primary refractory, and the median PFS was significantly improved to 12 months compared to 4 months with R-GemOx. And at 12 months, 49 or 50% of patients were actually in remission with Mosun Pola versus much lower with R-GemOx. Median overall survival, the follow-up was short, but there was a trend to improvement, and benefits were across all key subgroups, including geographic location, lines of therapy, refractory disease. Very importantly, was that the CRS was very low. So rare CRS events early, and they were low grade. So 26% CRS mostly was just a fever, which is grade 1 CRS. There were only like 4 or 5% grade 2 CRS and no grade 3, grade 4. And so majority of patients did not have CRS. And then only 4% of patients received steroids, and only 4% received tocilizumab. So I think a very powerful combination with low toxicity, in relapsed refractory DLBCL would be a great option. There were no ICANS with this combination, and extremely well tolerated with only 2% discontinuation rate for Mosun Pola. And the third study, which was updated and already presented previously but updated at ICML, was the STARGLO study, which looked at fixed duration combination of glofitamab GemOx to R-GemOx. And in this study, the median prior lines of therapy was 1, again, close to 60% primary refractory patients, similar to the SUNMO study. And there was a significant improvement in both median PFS as well as median overall survival with glofitamab GemOx compared to R-GemOx. And at 18 months, nearly half the patients were still in remission with glofitamab GemOx. What was updated at ICML was among patients who achieved a complete remission at end of treatment, about 80% or so were remaining progression-free. So at the longer follow-up, there was a question about potential curable. Although we have to wait a little bit longer, I think we could think about this as a potential curable regimen, especially if we see 3 years and 4 years. These patients are still maintaining a remission, especially if they underwent a complete remission. And I think that would be a huge advancement in the field. CRS was about 45%, mostly low-grade CRS, and very low ICANS, just 2%. Interestingly, we also participated in a Mosun plus Pola study in relapsed refractory mantle cell lymphoma, which was also presented at ICML. And this had a very high overall response rate of 88% with nearly 80% CR rate. And interestingly, in the P53 mutated patients, it was like a 90% CR rate, which is really amazing to see, especially in the relapsed refractory setting. And the responses were also durable, because at 12 months, about 2/3 of the patients maintained the response. And the median PFS in this study was a little more than a year and a half. And this is very encouraging data, knowing that the population of patients treated in this relapsed refractory mantle cell study with Mosun Pola were 100% BTKI exposed, and 30% had failed a transplant. About 1 in 4 patients had failed CAR-T, and 40% of them had mutated P53. So very high-risk population. And you're seeing very high response rates, durable responses with Mosun Pola. So I think Mosun Pola was a big hit for both relapsed refractory DLBCL as well as relapsed refractory mantle cell lymphoma. There was another study in relapsed refractory DLBCL, which was presented again going along with the theme of combining a bispecific antibody with ADC. And this was a single-arm study of glofitamab plus loncastuximab in about 40 patients. But I think it was very interesting. Again, over 50% were primary refractory. They had, really good responses in this study with CR rate of 87%. So really high, and we don't have long-term follow-up with this study, but I think this is also a very powerful combination and probably will be studied in a wider population. One other study of combining chemotherapy with bispecific antibody was EPCO-RICE, which was actually presented at EHA with nearly 87% response rate, and about 2/3 of patients achieved a CR. So I think this is an important study as well, because some late relapse patients may go for autologous transplant, and achieving a complete remission before autologous transplant can drive outcomes after autologous transplant. So, if you get a very high CR rate, which with EPCO-RICE is achievable, I think that is very helpful. So I think that's sort of like my takeaways for relapsed refractory as well as frontline DLBCL, and a little bit of segue into mantle cell lymphoma. The next I'd talk about follicular lymphoma. And again, the same theme that follicular lymphoma, we have bispecific antibodies, epcoritamab, mosunetuzumab, approved in third line plus, and they've been moving up, in fact, moving up to even frontline. So the MorningSun study was presented with fixed duration mosunetuzumab subcut in frontline high tumor burden follicular lymphoma, and it showed a high overall response rate of 86% with 60% CR rate. And at 12 months, which is a short follow-up for a disease like follicular lymphoma, especially in the frontline setting, but it was encouraging to see that over 80% of patients were still in remission at 12 months. And remember, mosunetuzumab is fixed duration, so patients have already stopped therapy at that point. And CRS rate was about a third of patients had CRS. Mostly they were grade 1. There were, in fact, no grade 3 or grade 4 CRS. Tocilizumab use was minimal. Only 6% of patients had needed tocilizumab. And there was another study which was also presented for frontline use of mosunetuzumab subcut in high tumor burden follicular lymphoma. This was presented by Dr. Falchi from Memorial Sloan Kettering, and in this study, overall response rate was even higher at 95% with CR rate of 82%. And again, with this study at 12 months, nearly 90% of patients here were still maintaining their remission. CRS was again low grade for the most part. While I've talked so much about bispecific antibodies, I'd like to highlight that in relapsed refractory follicular lymphoma, the InMind study was presented by Dr. Laurie Sen at ICML, and this showed significant improvement in PFS with tafasitamab plus rituximab plus lenalidomide versus rituximab lenalidomide, with a median PFS of 22 months with TAFA R-square versus 14 months with R-square. The benefit was sustained across all subgroups. Time to next treatment was not reached with TAFA R-square, and it was about 30 months or so with R-square. There was no transformation seen in the TAFA arm, and 9 patients had transformation in placebo arm, but it was not really powered to look at these differences, but these were just presented as raw values. I think this is important. The reason I mention it is around that time, the FDA did approve TAFA, rituximab, lenalidomide as a treatment option in relapsed refractory follicular lymphoma. The last one I'd like to highlight was a study we were involved in looking at the influence of health disparities on clinical outcomes in patients with DLBCL in the US, and this was from large cooperative group studies. And we found that race and ethnicity did not appear to drive clinical outcomes. In fact, high social deprivation index scores and lack of insurance or only public insurance corresponded with worse PFS and OS, and that was also presented by Dr. Alakar at the ICML meeting.